Okay, we are back. Hello, it's Dmitry again, and today we'll be reading the Pathology chapter from the first day for the Step 1 2025 edition. Again, that's the USMLE Step 1 2025 edition, although the PDF that should be on your screen will be from the 2017 edition. So you can follow along on the screen from the 2017 edition, or you can follow along with my voice from the 2025 edition. They are more or less the same, however, there are some minor differences between the two in terms of organization and some of the content included. So from that, let's begin with a few quotes. I'll be reading my book for reference again. The quotes: digressions, objections, delight, and mockery. Carefree mistrust are signs of health. Everything unconditional belongs in pathology. Okay, whatever. Nietzsche, okay. You cannot separate passion from pathology any more than you can separate a person's spirit from his body. Seltzer, okay. And I got one from Mencken. I don't know what's with this author. They're really like into... have we had Mencken quotes in this book so far that I've read before? I think so. My business is not prognosis, but diagnosis. I am not engaged in therapeutics, but in pathology. Okay, so they find a quote where somebody mentions the word pathology in it, and they're thinking, this is gold, so whatever. Famous person says the word pathology. Let's go find a quote where that happens. The fundamental principles of pathology are key to understanding diseases in all organ systems. Major topics such as inflammation and neoplasia appear frequently in questions across different organ systems, and such topics are definitively high yield. Very true. For example, the concepts of cell injury and inflammation are key to understanding the inflammatory response that follows myocardial infarction, a very common subject for board questions. Similarly, a familiarity with the early cellular stages that culminate in the development of neoplasias, for example, like esophageal or colon cancer, is critical. Make sure you recognize the major tumor-associated genes and are comfortable with key cancer concepts such as tumor staging and metastasis. Finally, take some time to learn about the major systemic changes that come with aging and how these physiologic alterations differ from disease states. So again, your version's a little bit more brief, perhaps, slightly different. Okay. Pathology, inflammation. Well, my book says cellular injury, but I'll go into mine. Let's see if we have anything on cellular adaptations. Cellular adaptations, hypertrophy, hyperplasia, that kind of thing. Talk about it? Maybe not. This has been really my issue with this book, perhaps, is the PDF. So why don't you just read the PDF of the 2025 edition? Because I bought a physical book, not the PDF, for 2025. Okay, we're just gonna read it. Okay, we're just gonna read it. You're gonna follow along, I guess. Cellular adaptations, and we're in the category of pathology, cellular injury. So cellular adaptations, reversible changes that can be physiologic, for example, uterine enlargement during pregnancy, or pathologic, for example, myocardial hypertrophy secondary to systemic hypertension. If stress is excessive or persistent, adaptations can progress to cell injury. That is to say, significant left ventricular hypertrophy can lead to myocardial injury, leading to heart failure. Hypertrophy is an increase in the structural proteins and organelles leading to an increase in size of cells. The example would be cardiac hypertrophy. Hyperplasia is controlled proliferation of stem cells and differentiated cells, leading to an increase in the number of cells, for example, benign prostatic hyperplasia. Excess stimulation, for example, leading to pathologic hyperplasia, in the case of endometrial hyperplasia, which can progress into dysplasia or cancer. Atrophy. Atrophy, decrease in tissue mass due to the decrease in size, increase in cytoskeleton degradation via the ubiquitin proteasome pathway, and autophagy, programmed digestion of damaged / misfolded intracellular proteins, decrease in protein synthesis, and or number of cells, apoptosis. Causes include disuse, denervation, and loss of blood supply, loss of hormonal stimulation, poor nutrition. Metaplasia. Reprogramming of stem cells, leading to a replacement of one cell type by another that can adapt to a new stressor, usually due to exposure to an irritant such as gastric acid, leading to esophageal epithelium replaced by intestinal epithelium, called Barrett esophagus, or tobacco smoke, which leads to the respiratory ciliated columnar epithelium replaced by stratified squamous epithelium. It may progress to dysplasia, leading to malignant transformation with persistent insult. Example, Barrett esophagus, which leads to esophageal adenocarcinoma. Metaplasia of connective tissue can also occur, that is to say, for example, in myositis ossificans, the formation of bone within muscle after trauma. What about dysplasia? Dysplasia, disordered and precancerous epithelial cell growth, not considered a true adaptive response, characterized by a loss of uniformity of cell size and shape, pleomorphism, loss of tissue orientation, nuclear changes, that is to say, increase in nuclear cytoplasmic ratio, and clumped chromatin. Mild and moderate dysplasias, that is to say, do not involve the entire thickness of the epithelium, may regress with alleviation of inciting cause. Severe dysplasia often becomes irreversible and progression to carcinoma in situ, usually preceded by persistent metaplasia or pathologic hyperplasia. And we go from there into cell injury, but there's a little chart that exists. Again, I don't think this book has this. I think it's useful to understand what dysplasia is compared to some of these other things, but it might not be in this older version. So let's see if we can find cell injury then. Yeah, we found it. Cell injury. Well, I'll read the chart first. So normal cells, if there's a severe stress or injury, this can lead to irreversible injuries leading to necrosis or apoptosis. If you have normal cells and they have changes in cell size and number, you might have hyperplasia, which is more cells basically, hypertrophy where the cells get bigger, or atrophy where they kind of like degenerate, they become smaller. So normal cells, if they have changes in cell structure, might be dysplasia. Changes in cell type would be metaplasia. So let's say, again, we talked about that before, you switch from, let's say, a columnar cell to a cuboidal cell or something like that. Or you want to have a change in cell type and structure, what we call neoplasia. Both dysplasia and metaplasia, if there's a chronic irritant that's continuing to persist, can become a neoplasia, which is something you do not want to have, essentially. And when this transition into a neoplasia, that is an irreversible process. You cannot go from neoplasia into a normal cell. It's a pathological point. Same thing with apoptosis. If the cells are dead, they're not going to come back, essentially. Cell injury. We have reversible and irreversible cell injury. And okay. I'm trying to figure out I'm trying to find my landscape for this book. So cell injury, reversible cell injury, decrease in ATP leading to a decrease in the activity of the calcium and sodium-potassium ATPase pumps, leading to cellular swelling, cytosol, mitochondria, endoplasmic reticulum / Golgi, which is the earliest morphological manifestation. Okay. Ribosomal / polysomal detachment, which causes a decrease in protein synthesis. Plasma membrane changes, blebbing. Nuclear changes, for example, chromatin plumping. Rapid loss of function, for example, myocardial cells are non-contractile after 1 to 2 minutes of ischemia. And then myelin figures, aggregation of peroxidized lipids. Irreversible cell injury. Breakdown of plasma membrane leading to cytosolic enzymes, for example, troponin, leak outside of the cell. Influx of calcium leads to the activation of degradative enzymes. Mitochondrial damage and / dysfunction leading to a loss of electron transport chain leads to a decrease in ATP. Rupture of lysosomes leading to autolysis. Nuclear degradation, Pycnosis, nuclear condensation leads to karyorexis, nuclear fragmentation caused by endonuclease-mediated cleavage, which leads to a karyolysis, nuclear dissolution. Amorphous densities / inclusions in mitochondria. So we have normal cell right there, and it can become a what you call, well, it's just going showing this period of cell injury. So you have this situation where you have membrane blebbing. It's in your PDF as well. Membrane blebbing, nuclear chromatin clumping, ribosomal detachment, cellular swelling, and then this is going to become irreversible now. We go into irreversible cell injury. Now we have nuclear degradation, mitochondrial permeability, right? Plasma membrane damage, rupture of lysosomes and cytolysis, yep. And then the cell just dies. So, yeah. So basically, if you want to think about it, there's a stage of normal versus reversible injury, irreversible injury, and then eventually you have death. Really, that's you can't go bring the cell back after that, really. Now, we're going to go on to apoptosis, which was actually the first page in this book, I believe. Apoptosis. Okay. Apoptosis. ATP-dependent programmed cell death. Intrinsic, extrinsic, and perforin/granzymes B pathways leading to intrinsic, extrinsic, and perforin granzyme B pathways leading to activate caspases, cytosolic proteases, leading to a cellular breakdown including cell shrinkage, chromatin condensation, membrane blebbing, and formation of apoptotic bodies which are then phagocytosed. Characterized by deeply eosinophilic cytoplasm and basophilic nucleus, pycnosis, and karyorexis. Cell membrane typically remains intact without significant inflammation, unlike necrosis. DNA laddering, fragments in multiples of 180 BP, is a sensitive indicator of apoptosis. Intrinsic mitochondrial pathway. Involved in tissue remodeling and embryogenesis, occurs when a regulating factor is withdrawn from a proliferating cell population, that is to say, a decrease in IL-2 after a completed immunologic reaction, leading to apoptosis of proliferating effector cells, also occurs after exposure to injurious stimuli, that is to say, radiation, toxins, hypoxia. Regulated by the BCL2 family of proteins, BAX and BAC are, this is like a little mnemonic that they're using, BAX, BAX, and BAC, BAK, are pro-apoptotic, bad for survival, while BCL2 and BCLXL are anti-apoptotic, be clever, live. Be clever, live, okay. I don't really like these mnemonics, to be honest with you. But whatever, BAX and BAC form pores in the mitochondrial membrane, leading to a release of cytochrome C from the inner mitochondrial membrane into the cytoplasm, leading to an activation of caspases. BCL2 keeps the mitochondrial membrane impermeable, thereby preventing cytochrome C release. BCL2 overexpression, that is to say follicular lymphoma in T1418, leads to a decrease in caspase activation, leading to tumorogenesis. What about the extrinsic death receptor pathway? Ligand receptor interactions, FAST-L binding to FAST-CD95 or TNF-alpha binding to its receptor. FAST-L, is that ligand, FAST ligand? Yeah, FAST ligand interaction is necessary in thymic medullary negative selection. Autoimmune lymphoproliferative syndrome caused by defective FAST ligand interaction leading to failure of the clonal deletion leading to an increased number of the self-reacting lymphocytes. Presents with lymphadenopathy, hepatosplenomegaly, and autoimmune cytopenias. And when I say fast ligand, I mean fast to fast ligand interaction. So the Fas ligand is interacting with the Fas. Perforin/granzyme B pathway. Do I have that in here? I think that just added in at some point. So we'll just read that. So perforin/granzyme B pathway. Release of granules containing the perforin and granzyme B by immune cells, cytotoxic T cell, and natural killer cell, leading to perforin forms a pore for granzyme B to enter the target cell. So there's an apoptotic body, ligands for macrophage cell and receptors. You have a macrophage right there. Cytotoxic T cell, granzyme B, extrinsic death receptor pathway with TNF alpha and TNFR, Fas ligand, Fas. Just, you can look into that just to kind of understand the nature of this sort of, I guess this would be a cytoplasmic bleb, apoptotic body, that kind of thing. Okay, let's go on to necrosis. And for reference, this will be probably, in the context of this book, one of the shorter chapters. It's not necessarily going to be a short video per se, but it will be a comparatively shorter chapter. It would be in a one video live stream in all likelihood. Necrosis. Exogenous injury leading to plasma membrane damage, which leads to intracellular components leaking, leading to cell undergoes enzymatic degradation and protein denaturation. This leads to local inflammatory reaction, unlike apoptosis. Coagulative, you got type seen in due to histology. So coagulative necrosis, seen in ischemia/infarcts in most tissues except brain. It's caused by or due to ischemia of an or infarction. Injury denatures the enzymes leading to proteolysis blocked. Histology, preserved cellular architecture, cell outlines seen, but nuclei disappear, leading to increase in cytoplasmic binding of eosin stain. This leads to increase in eosinophilia and red/pink color. Liquefactive necrosis. This is some pretty nasty stuff. Caseous necrosis is also really nasty. But liquefactive necrosis, bacterial abscesses, brain infarcts. My book says CNS infarcts. Similar idea. Due to neutrophils release lysosomal enzymes that digest the tissue. Early, cell debris in macrophages. Late, cystic spaces in cavitation, CNS. Neutrophils and cell debris seen with bacterial infection. And I might want to bring down the graph a little bit for you. So the A picture we were talking about before with coagulative, this is what coagulative looks like right here in A. And then B, that picture you see, that's showing the liquefactive necrosis in that brain right there. Really nasty stuff. So where was I? So early cellular debris in macrophages, late cystic spaces in cavitation, CNS, neutrophils and cell debris seen with bacterial infection. Okay. Now let's talk about caseous necrosis. Caseous necrosis. Caseous necrosis. TB, seen in TB, systemic fungi like Histoplasma encapsulatum nocardia, due to macrophages wall off the infected organism, creating granular debris. This in the histology, and you can see in picture C for this, I believe. Fragmented cells and debris surrounded by lymphocytes and macrophages, granuloma, cheese-like gross appearance. It actually is gross looking, to be honest with you, but it's called gross because it's just on the big picture. It's not like a micro histology thing. It's not on the micro level. It's just like you just see with your own eyes. It has a cheese-ish kind of appearance. Of course, it probably doesn't taste like that, but that's kind of what presentation looks like. Now, fat necrosis. Enzymatic acute pancreatitis, saponification of peripancreatic fat. Yeah, again, that's kind of a weird, gross, sort of weird thing. Non-enzymatic, traumatic, for example, injury to breast tissue. Due to damaged pancreatic cells release lipase, which breaks down triglycerides, liberated fatty acids bind to calcium, leading to saponification, chalky white appearance. Now, saponification, for reference, that's the term we would use in terms of chemistry for the description of how you would make soap. Is called saponification, just for reference. Of course, you make soaps originally from fats. So, histology: outlines of dead fat cells without peripheral nuclei. Saponification of fat combined with calcium appears dark blue and on H&E stain. And that should be in picture D, as you can see right there. What about fibrinoid necrosis? Immune vascular reactions, that is to say polyarteritis nodosa, non-immune vascular reactions, that is to say hypertensive emergency or preeclampsia. So there's an immune and a non-immune type. Immune complex, well, it's due to immune complex deposition, type 3 hypersensitivity reaction, and or plasma protein, that is to say fibrin, leakage from the damaged vessel. Histology, vessel walls contain eosinophilic layer of proteinaceous material, as you can see in picture E. In your book, it says they're thick and pink. Okay. Last picture, same picture that I have in my book as well. Again, pretty gross. Gangrenous necrosis. Distal is found in distal extremity and GI tract after chronic ischemia. It's due to dry ischemia, which is shown in picture F. Right there, that's a dry ischemia. You also have a wet superinfection. So for dry ischemia is coagulative presentation. Very gross. And for the wet superinfection presentation, you will have a liquefactive superimposed on coagulative. So basically, gangrenous is not necessarily completely separate from these other necroses. It is within the context of coagulative, but it is, I guess, distinct in a certain sense. It might be considered a subset. If it's dry, it would be coagulative. If it is wet, it will have liquefactive superimposed on coagulative. Okay, and that was kind of gross, but hey, things like this do happen, so you just need to be aware of them. We will be going on to ischemia now. So ischemia. Ischemia. Inadequate blood supply to meet demand. Mechanisms include a decrease in arterial perfusion, that is to say atherosclerosis, or a decrease in venous drainage, that is to say testicular torsion, or Budd-Chiari syndrome, or shock. Regions most vulnerable to hypoxia, such as ischemia and subsequent infarction. And they have a list out there. Brain, and a susceptible region would be the ACA, the MCA, and the PCA, which means the anterior, middle, and posterior cerebral arteries, boundary areas, basically. It has an A and a B little annotation there. Let's read them out. It says here, A and B. Watershed areas, border zones, receive blood supply from most distal branches of the two arteries with limited collateral vascularity. These areas are susceptible to ischemia from hypoperfusion. Neurons most vulnerable to hypoxic ischemic insults include Purkinje cells in cerebellum and pyramidal cells of the hippocampus and neocortex. That's to say layers 3, 5, and 6. And your book actually has a better graph for that. There's a diagram right there showing the different regions that have this these sort of watershed areas where they're basically getting dual blood supplies. And unfortunately, compared to some places in the body where you have a dual blood supply, which is normally a good thing, because it's like, oh, well, if one thing gets knocked out, you have a second blood supply. In this case, it's not really that great in terms of perfusion. So if you just have limited perfusion for some reason, like I guess in this case atherosclerosis, because it's the most distal parts of those areas, it is sort of like a no man's land essentially. To think of an imperfect example, I'm going to give you the most ridiculous examples to explain something in the body. In Egypt and Sudan have a border dispute, for example, and there is a part of that border dispute which neither side claims the territory. They basically, because of how that system works, neither side claims a particular triangle of territory, I believe it is, between the two. And as a consequence, nobody administers it. It's basically no man's land. Nobody administers anything there. There's nobody who lives there, as far as I'm aware, or at least not any meaningful size of population. It's sort of like that. And a lot of, historically, when we talk about nations, they will have cities and administrative regions, capitals and stuff like that, but they won't be able to control the most peripheral parts of their territories. They might claim it, but they can't do anything about lawlessness or something like that going on there. This is a similar situation. The body has the most well perfused parts of the brain are going to be these areas that are obviously very proximal to where the arteries are able to properly provide blood for. But it's more difficult for it to provide blood in its most distal regions, which are being basically, in a certain sense, provided a dual supply in those watershed areas. Because those are the border zones. Those are the areas where it's kind of like difficult for it to get blood to effectively. And so if there's a difficulty in general in giving blood, then it's going to be, those are the places that are the first to go. I.e., if you have limited blood supply, you have atherosclerosis, whatever, those are the places you're going to most likely experience damage because those are the most distal parts of that frame. The same way that if you had for example, a country or a power in history, like a potentate or whatever, that was declining in power, the first places it's going to lose control over are the most distal territories where it's the most already kind of dubious as to whether or not their authority even exists there. It's more of on a paper kind of thing. And so it's really the places that are the most distal, where you have the least capacity to project anything to, those are the first places to go when you have a decline. So, anyway, onto the heart. So, what about the heart? If you have an issue of ischemia with the heart ischemia, it's in the subendocardium, left ventricle. What about the kidney? My book says a little bit more to it. Heart, susceptible region, subendocardium of the left ventricle, yellow lines in A, outline a subendocardial infarction. My book has a little depiction for that one. It's okay. It's basically just showing that subendocardial layer is, in fact, ischemic, essentially. It shows an infarction in that location, which means before it became infarcted, it was ischemic before. Kidney. Most susceptible region of the kidney, straight segment of proximal tubule, that is to say the medulla, and thick ascending limb in the medulla as well. So basically the two areas are going to be the straight segment of proximal tubule and the thick ascending limb, both of those are in the medulla. Okay. The liver, most susceptible region, area around the central vein, that is to say zone 3. Colon, splenic flexure, Griffith point, a rectosigmoid junction, Sudak point. And again, there's a little A to that as well, and it's for the same reason. Watershed areas or border zones receive blood supply from most distal branches of two different arteries with limited collateral vascularity. These areas are susceptible to ischemia from hyperperfusion. So I think I might have misspoken before. I think usually, and there might be some cases where this is true, but usually a lot of these places that get dual blood supplies, they are going to be the worst places to have a problem, or the first places to have a problem, because they just don't get very good blood supply from either location. And so the minute you start having problems, that's the first place to really experience it. Because again, that's the most peripheral, the most distal parts of the circulation for those particular arteries. Just be aware of that. Watershed places, again, we're talking about splenic flexure, we're talking about rectosigmoid junction, we're talking about those blue sections of the brain. Those are the watershed areas of the brain that are setting between the anterior cerebral artery, the middle cerebral artery, and the posterior cerebral artery. Okay, now on to types of infarcts. Types of infarcts. Red infarct occurs in venous occlusion and tissues with multiple blood supplies. That is to say the liver, the lung, which you can see in the picture here, the lung, intestine, intestines, and with reperfusion, that is to say after angioplasty. Reperfusion injury is due to damage by free radicals. And they say for your thing, the mnemonic is red equals reperfusion. Mine shows that too, but doesn't have the actual mnemonic below. Red reperfusion injury, okay. Okay, and it's that's because of free radicals, basically, which I think is reactive oxygen species, if I'm not mistaken. Let me make sure I'm confirm that as being correct. Reactive oxygen species reperfusion. Massive destruction burst of reactive oxygen species. Yes. Okay, so I'm seemingly correct. Let's go back into it. Pale infarct. Pale occurs in solid organs with single and arterial blood supply. That is to say the heart or the kidneys. And you can see a picture right there for, I believe, they show the heart, I believe. Is that right? Pale anemic infarcts, B, occur in solid organs with it. My picture is just different. I think it is the heart. My picture shows a different picture of a heart. But it is basically, as they say in your things, a pale anemic infarct. So, okay. What about inflammation? Well, my book says, again, free radical injury. So I'm not sure if this is in your book or not. Free radical injury, free radical injury. Here we go, free radical injury. Free radicals damage cells via the membrane lipid peroxidation, protein modification, DNA breakage, initiated via the radiation exposure, that is to say cancer therapy, for example, metabolism of drugs, phase 1, or redox reactions, nitric oxide, for example, inflammation, transition metals, for example, iron, copper, form free radicals via Fenton reaction, or white blood cells, which like neutrophils, macrophages, and oxidative burst. So white blood cell oxidative burst. So a lot of things can cause free radical production. Again, we're saying radiation exposure, drug metabolism, redox reactions, nitric oxide, transition metals, white blood cells, the white blood cell oxidative burst, all those things can cause it. Free radicals can be eliminated by scavenging enzymes, that is to say catalase, superoxide dismutase, glutathione peroxidase. Spontaneous decay, antioxidants, like for example vitamins A, C, and E, and certain metal carrier proteins, for example transferrin or ceruloplasmin. Examples include oxygen toxicity, retinopathy or prematurity, abnormal vascularization, bronchopulmonary dysplasia, reperfusion injury after thrombolytic therapy, drug/chemical toxicity, acetaminophen overdose with hepatotoxicity, carbon tetrachloride converted by cytochrome P450 into CCl3, which I guess would be carbon chloride. What do you call that technically speaking? I want to make sure that I'm not saying anything incorrectly. CCl3. That is it's like monocarbon trichloride. What would you even call that? Trichloride. I don't know what you would call that. Antimony trichloride? I don't think that's what that is. Is it? No, it's definitely not. Is it? It's definitely not carbon tetrachloride because it's not. I guess it might be a carbon trichloride then. I don't really know what that means. Apologies on that. Where was I? Okay, examples, oxygen toxicity, okay. So drug chemical toxicity, acetaminophen overdose, carbon tetrachloride, I'm silly. Converted by cytochrome P450 into carbon trichloride free radical, leading to fatty liver, cell injury, leading to a decrease in apolipoprotein synthesis, leading to fatty change, and central lobular necrosis. Metal storage diseases like hemochromatosis with iron or Wilson's disease with copper. Obviously, those would be related to the whole thing we talked about before. We say, oh, well, we talked about transition metals can cause it. So, like, transition metals in my book says iron and copper. Well, if you have a condition where you have a metal storage disease, well, then you can have the same problem, right? Anyway. And that's why they're called, by the way, that's why they're called antioxidants, because they're trying to remove those reactive oxygen species, which are basically free radicals hanging around and causing problems, potentially. Trying to find ionizing radiation toxicity. We have a page on that. Yeah, I don't think we do have one. Okay, I'm going to take a short break. So ionizing radiation toxicity. Ionizing radiation causes DNA, does say double-strand breaks, and cellular damage both directly and indirectly through the reproduction. Ionizing radiation causes DNA and cellular DNA, for example, double-strand breaks, and cellular damage both directly and indirectly through the production of free radicals. Complications usually arise when a patient is exposed to significant doses, that is to say radiotherapy, nuclear reactor accidents. Localized inflammation and fibrosis, and neoplasias, for example leukemia or thyroid cancer. Acute radiation syndrome develops after sudden whole-body exposure to high doses of ionizing radiation, leading to nausea, vomiting, diarrhea, hair loss, erythema, cytopenias, headache, and altered mental status. Stem cells are rapidly regenerating tissues, as to say skin, bone, marrow, GI tract, gonads, are the most susceptible to radiation injury. Radiotherapy damages cancer cells more than healthy cells because cancer cells have dysfunctional DNA repair mechanisms in addition to high replicative rates. So, it's for some reason the chemotherapy drugs are useful against cancers is because a lot of the chemotherapy drugs are basically they're like anti-growth factors. They prevent growth from happening, prevent cells from dividing and reproducing, and so cancers which rapidly reproduce are going to be most affected by it, but they also cause myelosuppression, so you might have issues with your immune system, you might have issues with these kinds of things. And likewise, if you radiation therapy, again, radiation therapy is going to be most useful for cells that are rapidly reproducing and cells that are going to, in this case, also they can't actually repair DNA as effectively. So it's most useful in the context, of course, it's pretty harsh on the body itself, right? So let's talk about types of calcification now. This is in the book, definitely. Here we go. Types of calcification. Calcium deposits appear deeply basophilic, which is shown in the picture, I believe. Well, I have a picture of it, but the picture that you have actually in A should be fine as well, on H&E stain. We have dystrophic calcification and metastatic calcification. Let's talk about the dystrophic first. So we have calcium distribution, extent, associated conditions, and etiology. So dystrophic calcification, this calcium deposition is in abnormal, as I say, diseased tissues. The extent tends to be localized, calcific aortic stenosis, for example, and associated conditions, TB, lung and pericardium. When I mean TB, I mean tuberculosis, a lung and pericardium, and other granulomatous infections, liquefactive necrosis of chronic abscesses, fat necrosis, infarcts, thrombi, schistosomiasis, congenital CMV, toxoplasmosis, rubella, Samoma bodies, Crest syndrome, atherosclerotic plaques can become calcified. Etiology is secondary to injury or necrosis. Metastatic calcification. This is going to have calcium deposition in normal tissues. Extent for it is widespread, that is to say diffuse metastatic. It's associated with predominantly interstitial tissues of kidney, lung, and gastric mucosa. These tissues lose acid quickly. There's an increase in pH favors calcium deposition. Nephrocalcinosis of collecting ducts may lead to nephrogenic diabetes insipidus and renal failure. Etiology is secondary to hypophosphatemia, for example in chronic kidney disease, or hypercalcemia, that is, for example, in primary hypoparathyroidism, hyperparathyroidism, I should say, sarcoidosis, and hypervitaminosis D. So that makes sense, I guess, right? Right, you have these conditions that are increasing calcium levels or encouraging it being taken up by the bone. So, for example, if you have high PTH levels, you have more calcium hanging around. If you have more phosphate, you're going to encourage more calcium deposition into the bone, so this stuff would kind of cause these issues. I guess phosphate in that case is somehow leading to tissue deposition. I'm not exactly sure the mechanism for that. Etiology. Serum calcium levels in your book, as it says here as well. So for dystrophic calcification, it would be patients are usually normal calcemic. Okay, makes sense. But if you have metastatic calcification, usually patients are usually not normal calcemic. Okay. Because again, with dystrophic, it's a localized problem because of a diseased abnormal tissue. Metastatic calcification is a systemic problem that affects normal tissues, well, previously normal tissues. We can talk about psammoma bodies. If I can find a page on that for you. Looking for psammoma bodies and amyloidosis. This is admittedly a little more annoying part of my job here as somebody who's trying to figure out where things are located. Oh, here we go. Wow, that's really far back. Psammoma bodies, concentrically laminated calcified spherules, usually seen in certain types of tumors. And here's a little list that gives you P, papillary carcinoma of thyroid gland and kidney, SO, I should say, somatostatinoma, M, meningioma, M, mesothelioma, O, ovarian serous papillary cystoadenoma, cystoadenocarcinoma, and then M, milk, prolactinoma. Okay. Histology, leading to basophilic staining of calcium deposits within tissue. And so they have a little mnemonic that says psammoma bodies. Your thing has similar mnemonic, except there's fewer letters attached to it, but similar idea. What else do we have? We'll go on, I guess. On to amyloidosis. Wow, that's a completely different part of the chapter, isn't it? Amyloidosis. Yeah, it actually makes more sense in your book when I put amyloidosis in the context of just pathology, inflammation. Oh, maybe not, because this whole thing is pathology. I'm thinking, like, wouldn't you put the amyloidosis in the pathology section? Like, this is the pathology chapter. Okay. Amyloidosis, extracellular deposition of protein in abnormal fibrillar form, beta-pleated sheet configuration, leading to cell injury and apoptosis. Manifestations vary depending on the involved organ and include renal, nephrotic syndrome, cardiac, restrictive cardiomyopathy, GI, hepatosplenomegaly, neurologic, peripheral neuropathy, MSK, musculoskeletal, muscle enlargement, macroglossia, carpal tunnel syndrome, skin, waxy, thickening, easy bruising. Amyloid deposits are visualized by Congo red stain, red/orange on non-polarized light, and apple green birefringence on polarized light, and H&E stain, amorphous pink. And so you can see the Congo red stain here in picture A. You can see the polarized light, apple green birefringence with B right there. And I think, and C shows the actual, shows deposits of glomerular mesangial areas, white arrows. Okay. So there's different kinds of amyloidosis, which we're going to go into now. Common types, fibril protein associated with it, and then the notes. So primary amyloidosis, AL, from Ig light chains, seen in plasma cell dyscrasias, for example, multiple myeloma. Okay. Secondary amyloidosis, AA, serum amyloid A, seen in chronic inflammatory conditions, for example, rheumatoid arthritis, IBD, familial Mediterranean fever, and protracted infection. Transthyretin amyloidosis has fibroprotein transthyretin. It's sporadic, wild-type TTR, slow progressive associated with aging, mainly affects the heart, hereditary mutated TTR, familial amyloid polyneuropathy, and or cardiomyopathy. Dialysis-related amyloidosis. Fibroproteins beta-2 microglobulin, seen in patients with ESRD on long-term dialysis. Localized. Alzheimer's disease, beta amyloid protein, cleaved from amyloid precursor protein. Isolated atrial amyloidosis, ANP, common associated with aging, increase in risk for atrial fibrillation. Medullary thyroid cancer, calcitonin, right, that is secreted from tumor cells. Calcitonin deposition tumor cells and medullary carcinoma of the thyroid. Okay. And that actually concludes that section on cellular injury. Now we'll be talking about inflammation. So let's see that what we have here. Inflammation, wherever that might be. I just don't know how this is organized. Okay. Now we're this. So before I began on inflammation, which is interesting. I don't know who organizes this, but we'll look at it. Inflammation, It has rubor, calor, that kind of thing. Tumor, dolor, functoliasa, is that how you say it? ISA, yeah, I would assume. You know, sometimes you can't tell. Because if you don't know the font, you can't tell if that's a capital I or an L, lowercase l. Is anything that's rubor or calor? I don't know. Also, still not that, okay. Oh, here's the stuff about normal cells and dysplasia. Here we go. Well, if you want to review that, you can. Just look at this. Okay, that's what it looks like, okay. This is tumor grading staging. I just do not understand how they organize this chapter, or why they felt the need to reorganize this to such a degree. I suspect they suppose that most people don't buy or don't have access to two different copies and are trying to read from both or something. Okay, I'll take a short break. Okay. Pathology. Inflammation section. Inflammation responds to eliminate initial cause of cell injury, to remove necrotic cells resulting from original insult, and to initiate tissue repair, divided into acute and chronic. The inflammatory response itself can be harmful to the host if the reaction is excessive, for example in septic shock, prolonged, for example persistent infections such as TB, or inappropriate, for example in autoimmune diseases such as lupus, SLA. Signs and mechanism. Here's some cardinal signs. Rubor and calor. Redness and warmth, which is what they mean. Vasodilation, relaxation of arteriolar smooth muscle, leading to an increase in blood flow, mediated by histamine, prostaglandins, bradykinin, and nitric oxide. Tumor. You say, we mean tumor? Like, no, tumor, because it's spelled the same way, but you think about rubor, calor, tumor, dolor. So tumor, swelling, endothelial contraction / disruption, for example, from tissue damage, leading to an increase in vascular permeability, leading to a leakage of protein-rich fluid from postcapillary venules into interstitial space, exudate, leading to an increase in interstitial oncotic pressure. Endothelial cell contraction is mediated by leukotriene C4 and D4 in E4, histamine, serotonin, bradykinin. Dolor, pain, sensitization of sensory nerve endings, mediated by bradykinin, PGE2, and histamine. Functiolysa, I would assume is what that means. Functiolysa. Let me just make sure that I'm not saying that incorrectly. I really do hate when there's a ambiguity. It's functiolysa. And I'm probably butchering that, nevertheless. Loss of function, inflammation impairs function, that is to say, the inability to make first due to hand cellulitis. Systemic manifestations, acute phase reaction. Now we're going to these other stuff here. So systemic manifestations. Fever. Pyrogens, example LPS, induce macrophages to release IL-1 and TNF, leading to an increase in COX activity in the perivascular cells of anterior hypothalamus, which leads to an increase in PGE2, leading to temperature set point increasing. Again, that's fever with prostaglandin E2. Leukocytosis. Increase in white blood cell count, type of predominant cells depends on inciting agent or injury, that is to say bacteria, leading to increase in neutrophils. Increase in plasma acute phase. Serum concentration significantly change in response to... Increase in plasma acute phase reactants. This will have serum concentration significantly change in response to acute and chronic inflammation, produced by liver, notably induced by IL-6. What about some acute phase reactants? Again, I'm not sure if they mentioned this or not. Acute phase reactants. You'd think they would have it somewhere, right? It looks like they don't, so... Acute phase reactants. Positive, upregulated. C-reactive protein, opsinin, fixes complement and facilitates phagocytosis, measured clinically as a nonspecific sign of ongoing inflammation. Ferritin, binds and sequesters iron to inhibit microbial iron scavenging. Fibrinogen, coagulation factor, promotes endothelial repair, correlation with ESR. Haptoglobin, binds extracellular hemoglobin, protects against oxidative stress. Hepcidin, decrease in iron absorption by degrading ferroportin, and decrease in iron release from macrophages, leading to an anemia of chronic disease. Procalcitonin, increases in bacterial infections. And serum amyloid A, prolonged elevation can lead to secondary amyloidosis. What about negative, downregulated? Albumin, reduction conserves amino acids for positive reactants. Transferrin, internalized by macrophages to sequester iron. Transthyretin, also called prealbumin, reduction conserves amino acids for positive reactants. Now we're talking about erythrocyte sedimentation rate, which is ESR. Again, I'm not quite sure exactly where this is located in this book. Here we go, ESR. So erythrocyte sedimentation rate. RBCs normally remain separated by the negative changes. Products of inflammation, example fibrinogen, coat RBCs, leading to a decrease in negative charge, which leads to an increase in RBC aggregation. Denser RBC aggregates fall at a faster rate within a pipette tube, leading to an increased ESR, often co-tested with CRP, which is more specific marker of inflammation. So increase in ESR is going to be found. Elevated ESR is going to be found in most anemias, infections, inflammation, for example, giant cell temporal arteritis, polymyalgia rheumatica, cancer, example, metastases, multiple myeloma, renal disease, end-stage or neutrophilic syndrome, and pregnancy. ESR, decrease in ESR, might be found in something like sickle cell anemia with altered shape, polycythemia with increased RBCs which dilute the aggregation factors, heart failure, microcytosis, and hypofibrinogenemia. And there's a little annotation for A for decreased ESR, which says lower than expected. Doesn't mean necessarily that it's lower in the actual antecedent thing for what causes ESR is going to be low in absolute terms. It's just that it's going to be lower than what we would expect for ESR when measuring it. Now we're talking about acute inflammation, which is going to be talking about stimuli, mediators, components, and that kind of thing. Again, I'm not really sure why that's not talked about in a more direct sense for this, but, what can you do? Acute inflammation. There's a little section here about it right here, I guess, in your book. Mine's a little bit longer, of course. Acute inflammation, transient and early response to injury or infection, characterized by neutrophils in tissue, often with associated edema, rapid onset, seconds to minutes, and short duration, minutes to days, represents a reaction of an innate immune system, that is to say, less specific response than chronic inflammation. Stimuli, mediators, components, and outcomes. So, acute inflammation stimuli, infections, trauma, necrosis, foreign bodies. Mediators, toll-like receptor, arachidonic acid metabolites, neutrophils, eosinophils, antibodies, pre-existing, mast cells, basophils, complement, and Hageman factor, which is factor 12. An inflammasome is a cytoplasmic protein complex that recognizes the products of dead cells, microbial products, and crystals, for example, uric acid crystals, leading to an activation of IL-1 and inflammatory response. What about the components of acute inflammation? Vascular, vasodilation leading to an increase in blood flow and stasis, and an increase in endothelial permeability, causing or having a contraction of endothelial cells open interendothelial junctions. Cellular, extravasation of leukocytes, mainly neutrophils, from postcapillary venules, leading to an accumulation of leukocytes in focus of injury, leading to leukocyte activation. To bring cells and proteins to protein site of injury or infection. Leukocyte extravasation has 4 steps: margination and rolling, adhesion, transmigration, and migration, chemoattraction. The outcomes? Resolution and healing, IL-10, TGF-beta. Those are supposed to be the ones that actually kind of wind down inflammation. Persistent acute inflammation with IL-8. Abscess acute inflammation walled off by fibrosis. And chronic inflammation, antigen presentation by macrophages and other APCs, leading to activation of CD4 positive T cells. And scarring. Basically, those are sometimes different outcomes. So, for example, if you want to wind down the whole process and have resolution healing, you do IL-10 TGF-beta. If you want to have to be persistent, you can use IL-8. Basically, there's different outcomes you might have for this. It's not one particular outcome per se. Now, with that, macrophages predominate in the late stages of acute inflammation. Peak is 2 to 3 days after onset, and influence outcomes by secreting cytokines. Leukocyte extravasation. Extravasation predominantly occurs at postcapillary venules. Your book also says, white blood cells exit from blood vessels at sites of tissue injury and inflammation in 4 steps. So step 1, margination and rolling. Step 2, tight binding, adhesion. Step 3, diapedesis, transmigration. And step 4, migration. But let's go into each step more specifically. So step 1, margination and rolling. Defective in leukocyte adhesion, deficiency type 2, decrease in Lewis X. Vascular stroma and leukocytes. Vascular stroma, E-selectin, upregulated by TNF and IL-1. P-selectin, translocated to endothelial surface via exocytosis from vivo Pilati bodies. Glycam-1, CD34. Leukocyte would include Lewis X, and L-selectin. Okay. I'm going to assume for those 3 different particular things. They talk about Glycam-1, CD34 for L-selectin, and then E-selectin, P-selectin for Lewis X, basically. What about tight binding? Adhesion. Defective in leukocyte adhesion deficiency type 1, decrease in CD18 integrin subunit. So you have ICAM-1, CD54, which will be related to CD11/18 integrins, LFA1, MAC1, and then VCAM, CD106, VLA4 integrin. Okay. What about diapedesis, transmigration? White blood cell travels between endothelial cells and exits the blood vessel. You have PCAM1, CD31, PCAM1, CD31. 4. Migration. White blood cell travels through interstitium to site of injury or infection guided by the chemotaxic factors, chemotaxic signals. Chemotoxic factors include, well, I guess I was right. Chemotoxic factors, C5A, IL-8, LTB4, 5-HETE, 5-HEAT, I guess maybe, kallikrein, platelet activating factor, and N-formylmethionine peptides. The leukocytes for this will be various. So here's a little diagram. I feel like that one's not a very good way of conveying it. There's a good, I think, either a Pathoma video or a Boards and Beyond video, maybe both, that is good at explaining the process of the migration of some of these neutrophils and that kind of thing, going from margination, tight binding, diapedesis, and migration. And I think it communicates it a little bit better than this does. But this diagram is useful. See margination rolling, right? Binding to the Z-selectins, you're trying to get it to slow down with rolling. Margination is the process of actually getting into the margins of the actual vessel, which then you can go from there and actually get it to start binding to the Z-selectins, kind of slowing it down. Eventually it starts binding to things in the process of tight binding, which involves ICAM, right? It starts using ICAM and these sorts of LFA, whatever, that kind of thing. And then eventually you have diapedesis, where starts actually going, where this transmigration starts entering into the layer, right? And then from there, you have a process of migration where it actually uses these chemotoxic factors to go travel into the location that it's actually needed at, which might involve things like IL-8, LTB4, kallikrein, C5A, that kind of thing. I have a good diagram of myself for this kind of stuff. It's good to have diagrams that you can draw out that helps communicate to you what you think is important based on what you're reading from the material, of course. Free radical injuries, what your book says, I'm looking for something called chronic inflammation. So maybe I have to go back up. Take a short break. Okay, chronic inflammation. Chronic inflammation, prolonged inflammation characterized by mononuclear infiltration, macrophages, lymphocytes, plasma cells, which leads to simultaneous tissue destruction and repair, including angiogenesis and fibrosis, may be preceded by acute inflammation. The stimuli, persistent infections, example TB, T. pallidum, which is also called, T. pallidum I believe is going to be, I want to misspeak on this. T. pallidum, I don't know whether T. pallidum is going to be treponema pallidum, right? Treponema pallidum, a thinly coiled negative spirochete, causes syphilis, Just FYI, so TB, T. pallidum, certain fungi and viruses, leading to a type 4 hypersensitivity, autoimmune disease, prolonged exposure to toxic agents, for example silica, and foreign material. Mediators, macrophages are the dominant cells, interaction of macrophages and T cells leading to chronic inflammation. Helper Th1 cells create the interferon gamma, leading to macrophage classical activation, pro-inflammatory. Th2 cells secrete IL-4 and IL-13, which leads to macrophage alternative activation, repair, and anti-inflammatory. Outcomes, scarring, amyloidosis, and neoplastic transformation. That is to say, chronic HCV infections leading to chronic inflammation, leading to hepatocellular carcinoma, Helicobacter pylori infection leading to chronic gastritis, leading to gastric adenocarcinoma. So basically, if there's a continuing stimulus That's acting on this. That's a noxious stimulus. It can lead to something that is cancerous. What about wound healing? Wound healing. Tissue mediators. We have mediator and the role. So we have FGF. FGF does what? Stimulates angiogenesis. TGF beta, which involves in angiogenesis and fibrosis. VEGF, which is VEGF, is involved in stimulating angiogenesis. PDGF, which is platelet-derived growth factor, secreted by activated platelets and macrophages, induces vascular remodeling and smooth muscle cell migration, stimulates fibroblast growth for collagen synthesis. Metalloproteinases, which is involved in tissue remodeling, and EGF stimulates cell growth via tyrosine kinases, for example, EGFR/ERB1 or ERB1. Phases of wound healing. Effector cells and characteristics. Inflammatory up to 3 days after wound. Platelets, neutrophils, macrophages. Characteristics: clot formation, increased vessel permeability, and neutrophil migration into tissue. Macrophages clear debris 2 days later. Proliferative day 3, weeks after wound. Fibroblasts, myofibroblasts, endothelial cells, keratinocytes, macrophages. Deposition of granulation tissue in type 3 collagen. Where was I? Sorry. Deposition of granulation tissue in type 3 collagen, angiogenesis, epithelial cell proliferation, dissolution of clot, and wound contraction, mediated by myofibroblasts, delayed second phase of wound healing, and vitamin C and copper deficiency. But that's proliferative wound. That's proliferative type, day 3 to weeks after wound. Okay. Remodeling, 1 week to 6 months after wound. Fibroblasts. You will have type 3 collagen replaced by type 1 collagen, leading to an increase in tensile strength of the tissue. Collagenases require zinc to function, break down type 3 collagen. A zinc deficiency would lead to a delayed wound healing, of course, if that's the case, right? Granulomatous inflammation. A pattern of chronic inflammation can be induced by persistent T cell response to certain infections, for example, TB, immune-mediated diseases, and foreign bodies. Granulomas wall off a resistant stimulus without completely eradicating or degrading it, leading to persistent inflammation, leading to fibrosis and organ damage. And there's a little picture for you as well you can see, and I think we'll get into that. For the histology of granulomatous inflammation, focus of epithelial cells activated macrophages with abundant pink cytoplasm surrounded by lymphocytes and multinucleated giant cells formed by fusion of several activated macrophages. 2 types: caseating, associated with central necrosis, and seen with infectious etiologies, for example, in TB or fungal. Non-caseating types, so no central necrosis, seen with non-infectious etiologies like sarcoidosis and Crohn's disease. So that's an important distinction to make, because they might have a question that you have on your exam that says, oh, the patient has caseating necrosis, where they say they have non-caseating necrosis. When you hear caseating necrosis, think about specifically caseating necrosis. Think about TB or something fungal, something like that. If it's non-caseating, very important, non-caseating, think about sarcoidosis or Crohn's disease, something like that, because they will have questions like that. They mentioned there's this name drop. They just drop, oh, this non-caseating. Know what that might mean. When it says caseating, know what that might mean, because that's probably going to be the answer, one of those handful of answers, and you will figure it out based off the other kinds of context clues. What's the mechanism behind granulomatous inflammation? Mechanism. 1. This is a 1 through 3. 1. APCs present antigens to CD4 positive helper T cells and secrete IL-12, leading to CD4 positive helper T cells to differentiate into Th1 cells. Th1 cells secrete interferon gamma, leading to macrophage activation. Yep. macrophages increase cytokine secretion, for example, TNF, tumor necrosis factor, leading to a formation of epithelial macrophages in giant cells. Anti-TNF therapy can cause sequestering granulomas to break down, leading to disseminated disease. Always test for latent TB before starting anti-TNF therapy. Associated with hypercalcemia due to an increase in 1-alpha hydroxylase activity in activated macrophages, resulting in increase in vitamin D activity. And mine has a picture that yours does not, unfortunately. But this just shows basically there's interaction betwixt the T cell and the antigen-presenting cell. They're kind of like co-activating each other, essentially. There's going to be a sending of IL-12 from the APC, again, antigen-presenting cell, to the T cell, and it's presenting the antigen to it. The T cell becomes a Th1 cell, right? And that Th1 cell releases interferon gamma, which is going to go and cause the macrophage to become activated, and then the activated macrophage will release TNF, and that will cause this granuloma to form. You have epithelioid cells, fibroblasts, lymphocytes, and giant cells, of course, which are, I think, made from macrophages. And now we're talking about etiologies, I think, so part of the granulomatous inflammation section, so I'll go back up to that, I guess. Infectious versus non-infectious etiologies. Let's talk about infectious etiologies. Bacterial, mycobacterium, tuberculosis, leprosy, Bartonella henselae, cat scratch disease, stellate necrotizing granulomas, Listeria monocytogenes, granulomatosis infantiseptica, Treponema pallidum, which is tertiary syphilis, related to that. Fungal, endemic mycoses, histoplasmosis, parasitic, schistosomiasis, catalase-positive organisms in chronic granulomatous disease. Non-infectious, immune-mediated sarcoidosis, Crohn's disease, primary biliary cholangitis, subacute Dequer veins granulomatosis, thyroiditis. Vasculitis, granulomatosis with polyangiitis, eosinophilic granulomatosis with polyangiitis, giant cell temporal arteritis, Takayasu arteritis, foreign bodies, berylliosis, talcosis, hypersensitivity pneumonitis. Talking about scar formation now. So scar formation, where is it? We're going to have a picture of the keloid pretty soon. Maybe it's not even in this book. It might not be. Maybe not. No, it's here. That's a much nastier looking keloid. There's a picture of a, I think it might be a black man with a big keloid on his side, right below his ear. That one keloid right there looks a lot worse. If that is a keloid, I assume it is a keloid. Yeah, it's a keloid. Let's talk about scar formation. Scar formation. Occurs when repair cannot be accomplished by cell regeneration alone. Non-regenerated cells secondary to severe acute or chronic injury are replaced by connective tissue. 70 to 80% of tensile strength regained at 3 months. Little tensile strength regained thereafter. Excess TGF-beta is associated with aberrant scarring, such as hypertrophic and keloid scars. Scar formation. In your books, this is what my book said right there for that. Okay. So hypertrophic scars and keloid scars. The scar type, or as I say, collagen synthesis, collagen reorganization, extent of scar, recurrence, and predisposition. So hypertrophic scar. My book has the same picture of picture A. It says here, collagen synthesis is increased type 3 collagen. Organization is parallel. The extent would be confined to the borders of the original wound, and the recurrence is infrequent. Predisposition, none. What about keloid scar? Well, massive increase, significant increase in types 1 and type 3 collagen, so type 1 is also involved. It's disorganized. Its organization, disorganized. The extent extends beyond the borders of original wound with claw-like projections, typically on the earlobes, face, and the upper extremities, as you can see there on the face. For your picture, PDF, yeah. Its recurrence is frequent, and its increased incidence in people with darker skin. I don't know if they mean people who are just African, like sub-Saharan African, or they mean just dark-skinned people in general, like maybe if it's higher in, I don't know, Southern Indians or something, I'm not quite sure. Is keloids, are keloids associated with dark skin or with Africans? Okay, so keloids are fundamentally associated with dark skin rather than a specific geographic ethnicity. Okay, so they're much more common in Fitzpatrick skin types type 3. But, okay, so it looks like it's found in some other non-European populations. But the presumption is that it's from, they're presenting as it's a, so I guess they're saying that basically the reason that sub-Saharan Africans are more likely to get is because they have darker skin on average, and it seems to be related to having darker skin. Which presumably means that people who do not have dark skin and are non-sub-Saharan African will also have elevated risk. That's the implication. I'm not 100% sure if that's true, but that's what they're implying. That's what they're saying. I guess I could see that being the case. It's the mechanism that they're describing for why it's more common in those particular populations, because it's mediated by some sort of mechanism related to having dark features in the first place. Elevated melanin, that kind of thing. Now we're going to go into our next section on pathology neoplasia, which again, I'm not quite, oh, here we go. And so we'll go into that right now. Neoplasia. How long have I been streaming for this? An hour and 18. Okay, so yeah, this will probably take, I'm on page 215 right now for reference, and we probably will wrap up in 225, I believe. 225, yeah. It's pretty packed. It's not like necessarily, well, it's okay. It's okay reading. I wouldn't say it's particularly dense, and I'm in a decent mood right now, so probably won't be too crazy, but yeah, it might take another hour to wrap it up, because we're on 215 right now. We've read through maybe 15 pages-ish, that kind of thing, maybe 14 pages, and then we'll have another 10 or 11 pages to wrap up with. Pathology, neoplasia. Neoplasia and neoplastic progression. Uncontrolled, often monoclonal proliferation of cells can be benign or malignant. Any neoplastic growth has two components: parenchyma, neoplastic cells, and supporting stroma, non-neoplastic, that is to say blood vessels, connective tissue. And mine has a chart that shows epithelial cell, basement cell, membrane, epithelial cell layer, basement membrane, then has this thing that says blood or lymphatic vessel. 2, it shows this sort of discoloration, presuming that's some sort of irregularity. Then discoloration becomes very broad and takes up the entire, and there's originally a basement membrane layer in the first place. It kind of infiltrates the epithelial cells, and then it grows out into past the basement membrane, and it starts going into the vessels, and then it becomes like metastasizing. So it's basically showing the different steps. This is an okay chart. Maybe not necessarily. Let's see if we have a good chart. Here we go. This is what I'm talking about, neoplastic progression. So we start with normal cells, we go to dysplasia, then we have carcinoma in situ, right? It's still kind of under control, right? It's not good, but it's in situ. Then it's invasive. That's where the real problems start really begin to show themselves, And then you have metastasis. That's really bad. Okay, let's talk about normal cells. 1, normal cells with basal leading to apical polarity. See cervical example, which shows normal cells in spectrum of dysplasia, as discussed below. Dysplasia. Loss of uniformity in cell size and shape, pleomorphism, loss of tissue orientation, nuclear changes, that is to say, increase in nuclear cytoplasmic ratio, often reversible. Carcinoma in situ, para-invasive. 3, right? Irreversible severe dysplasia that involves the entire thickness of epithelium but does not penetrate the intact basement membrane. So it's still in situ, right? Still in location. Invasive carcinoma, this is where it goes bad. Cells have invaded the basement membrane using collagenases and hydrolases, metalloproteinases. Cell-cell contact lost by inactivation of E-cadherin. So it's no longer adhering to it necessarily, right? And it's trying to find its way invading through using these hydrolases and metalloproteinases, these collagenases and hydrolases and that kind of thing. And the cell-to-cell contact is lost, so they can kind of do their own thing now. Metastasis. Spread to distant organs via lymphatics or blood. That's very, very much not a good thing. And I think, by definition, that's stage 4, right? So let me just confirm that that's true. Are all metastases stage 4? I think by definition. Yeah, by definition they're stage 4. Okay. We're going to go into tumor grading, staging, and nomenclature. But I'm going to go take a short break, or a break. You can skip ahead if you need to if you're watching the replay. Okay, we are back. And, let me think. I definitely have built up some stamina when reading these kinds of things, although admittedly, when I go into them, I haven't read one of these in a while, for example. They have spent a few days and say, oh, I really want to get back into the chapters because I have to read them, But then I start reading them, I'm like, oh, do I really want to read the rest of this? It's like, yes, I kind of should, So I will. Now we're on to tumor nomenclature, and my book is ordered a little bit differently. I'll go back to tumor grade versus stage in a bit. So tumor nomenclature. The tumor nomenclature. Carcinoma implies epithelial origin, whereas sarcoma denotes mesenchymal origin. Both terms generally imply malignancy. Benign tumors are usually well differentiated and well demarcated, with low mitotic activity, no metastases, and no necrosis. Malignant tumors, cancers, may show poor differentiation, erratic growth, and local invasion, metastases, and a decrease in apoptosis. One of the important things that makes it a cancer rather than a benign tumor is not necessarily whether or not it has metastasized, because if it's metastasized, it's already a stage 4 cancer. It's the ability to metastasize. It's the potential for metastasis. For benign, in principle, there is no real risk for metastasis. For a malignant cancer, for something that's malignant tumor, it's a cancer, there is a risk for metastasis even if it has not happened yet. That's the idea. Terms for non-neoplastic malformations include hamartoma, disorganized overgrowth of tissues in their native location, for example, Putz-Jaeger's polyps, and choristoma, normal tissue in a foreign location, for example, gastric tissue located in distal ileum and Meckel diverticulum. So we also have some cell types, benign and malignant. So epithelium, the benign type would be adenoma or papilloma. The malignant would be adenocarcinoma and papillary carcinoma. Make sense? These are mesenchymal for the rest of them. Mesenchymal. So blood cells, they're just, leukocytes, reticulocytes. They don't really make, they're whatever, right? They're normal RBCs or white blood cells as well. What do you have them with their malignant? Leukemia and lymphoma. Blood cells. And leukemia, by the way, the leuc meaning white, that refers to the white blood cell. So for reference, okay. Blood vessels. You can have a benign hemangioma or a malignant angiosarcoma. Smooth muscle could have a benign leiomyoma or a malignant leiomyosarcoma. Striated muscle may have a rhabdomyoma or a malignant rhabdomyosarcoma. A benign, for connective tissue, a benign fibroma or a malignant fibrosarcoma. You may have a benign osteoma or a malignant osteosarcoma. For fat, you might have a benign lipoma or a malignant liposarcoma. For melanocytes, you might have a benign nevus or mole. You might see on the skin like a mole, or you might have a malignant melanoma. So let's talk about tumor grading versus staging. So tumor grade versus stage. For the grade, the degree of cell differentiation, tissue of origin resemblance, and mitotic activity on histology ranges from low grade, which is well differentiated, to high grade, poorly differentiated or undifferentiated anaplastic. Higher grade often correlates with a higher aggressiveness. Yet something's not right when it's high grade, essentially. What about staging? Well, stage is the degree of invasion and spread from the initial site. Depth of invasion correlates to risk of metastasis, based on clinical C or pathologic P findings. T and M, staging system, important. M greater than N greater than T. So M is metastasis, by the way. N is the node involvement, and then T is the tumor size / invasiveness. So again, primary tumor size / invasion, regional lymph node metastasis, and distant metastasis is M. So if you're talking about local invasion, if you're talking about invasion of local lymph node, that is N. But when we talk about M, we're talking about specifically the distal metastasis for M. Staging generally has more prognostic value than grading does. So staging generally has more prognostic value than grading. That is to say, higher stage yet lower grade is usually worse than a low stage yet high grade. Stage is the spread, determines survival. So again, and that's kind of connected to the fact that it's really asking the question of how invasive is the tumor, which is a little bit more important than how messed up looking is the tumor. Because, sure, they're connected, they're correlated. If the tumor looks really weird or messed up, that's not great. But if it's very obviously very aggressive and invading different tissues, that's more of an indication of how problematic it would be. So what are the hallmarks of cancer? There might not be that section in here, would there? Cancer epidemiology. I'll leave it on here. Just leave it at that, and I'll get into hallmarks of. I'll get into whatever section it is after that. Hallmarks of cancer. Oh, whack! This is crazy. My page says 217. This book says 217. So this is one of the rare cases where the pages actually are basically on top, right next to each other, as they are. Right, we're 216 before here, right? Yep, and 216 on my page here. So that's one of the few cases where they actually we're on the same page, essentially. Basically, everywhere else in the book, my book is longer than this book. So I guess at some point, the farther and farther you go, the more obvious the distinction will be made. But whatever. So, hallmarks of cancer. Cancer is caused by mostly acquired DNA mutations that cancer is caused by mostly acquired DNA mutations that affect fundamental cellular processes, like example, growth, DNA repair, and survival. Hallmark versus mechanism. Hallmark. Growth, signal, self-sufficiency. The mechanism would be mutations in genes encoding for proto-oncogenes, which leads to an increase in growth factors, autocrine loop leading to an increase in platelet-derived growth factor in brain tumors. Growth factor receptors, which lead to constitutive signaling, for example, HER2 in breast cancer. Signal molecules, for example, RAS, transcription factors like MYC, MYC. Is that offensive? I'm not sure. Cell cycle. If it was something else, you probably wouldn't be able to get away with it. But okay. Cell cycle regulators, cyclins, CDKs. Anti-growth signal insensitivity. Mutations in tumor suppressor genes, for example, RB. Loss of E-cadherin function leading to a loss of contact inhibition, that is to say, NF2 mutations. Evasion of apoptosis. Mutations in genes that regulate apoptosis, that is to say, TP53, BCL2, leading to follicular B-cell lymphoma. Limitless replicative potential. Reactivation of telomerase, leading to a maintenance and lengthening of telomeres, leading to prevention of chromosome shortening and cell aging. Sustained angiogenesis, leading to an increase in pro-angiogenic factors, that is to say VEGF, or a decrease in inhibitory factors. Factors may be produced by tumor or stromal cells. Vessels can sprout from existing capillaries, neoangiogenesis, or endothelial cells are recruited from bone marrow, like vasculogenesis. Vessels may be leaky and or dilated. Warburg effect. Shift of glucose metabolism away from mitochondrial oxidative phosphorylation towards glycolysis, even in the presence of oxygen. Aerobic glycolysis provides rapidly dividing cancer cells with the carbon needed for synthesis of cellular structures, leading to an increase in lactic acid. Immune evasion in cancer. Normally, immune cells can recognize and attack tumor cells. For successful tumorigenesis, tumor cells must evade the immune system. Multiple escape mechanisms exist, including the decrease in MHC class I expression by tumor cells, leading to a cytotoxic T cells are unable to recognize the tumor cells. Tumor cells secrete immunosuppressive factors, for example, TGF-beta, and recruit regulatory T cells, NTREGs, right, to downregulate the immune response. And tumor cells upregulate immune checkpoint molecules, which inhibit the immune response. which is pretty crafty, pretty impressive. Especially considering it's not a bacteria, it's not a foreign element. It's actually a deviant cell line from your own body, right? Tissue invasion. Loss of EC adherent function leads to a loosening of intercellular junctions, which leads to metalloproteinases degrade the basement membrane and ECM, which leads to cells to attach to ECM proteins, that is to say laminin and fibronectin, which leads to cells that migrate through the degraded ECM locomotion, leading to vascular dissemination. Metastasis. Tumor cells or emboli spread via lymphatics or the blood, leading to adhesion to endothelium, leading to extravasation and homing. Site of metastasis can be predicted by site of primary tumor, as the target organ is often the first encountered capillary bed. Some cancers show organ tropism, that is to say, lung cancers commonly metastasize to adrenals. Okay, what about immune checkpoint interactions? Do we have that in here? Maybe not. No, I don't think so. What about common metastases? Wow. Okay. Immune checkpoint interactions. Signals that modulate T cell activation and function, that is to say, which lead to a decrease in immune response against tumor cells. Targeted by several cancer immunotherapies. The examples would be the interaction between the PD-1 on T cells and PD-L1/2 on tumor cells or immune cells in tumor microenvironment, which lead to the T cell dysfunction, exhaustion, inhibited by antibodies against PD-1, that is to say, the semiplimab, nivolumab, and pembrolizumab, or PD-L1, that is to say, atezolizumab, durvalumab, and avelumab. CTLA-4 on T cells outcompetes the CD28 or 4B7 on APCs, which leads to a loss of T cell co-stimulatory signal. Inhibited by antibodies against CTLA-4, ipilimumab. Okay. Ipilimumab, atezolizumab, durvalumab, avelumab, semiplimab, nivolumab, pembrolizumab. Okay. These are just basically different antibodies that are showing in this little diagram that I have for APC in a tumor cell, and showing the impact on the T cell, on the impact related to things like T cell activation. So, for example, the APC having MHC class 2 interacting with the, presuming that's the antigen presentation with a T cell receptor, leads to a T cell activation. CD28 interacting with B7 leads to a T cell activation. A B7 from the APC interacting with a CTLA-4 causes a negative inhibition against T cell activation. On the tumor cell, the MHC class 1 interacting with the antigen on the T cell receptor causes a T cell activation, while the PD-L1 interacting with the PD-1 causes a inhibition against T cell activation. And there's various things like the ipilimumab, for example, which inhibits the CTLA-4 interaction, and these other ones like semiplimab, nivolumab, pembrolizumab, which are going to inhibit the PD-1, as we were talking about before, which would normally inhibit the T cell activation, and the atezolizumab, durvalumab, and evolizumab. Those are going to inhibit the PD-L1, which is going to interact with PD-1 to inhibit the T cell activation. So basically, all those MABs we were talking about before, they're all inhibiting these negative pathways which would otherwise inhibit T cell activation. So basically, they're indirectly promoting T cell activation by inhibiting these inhibitory pathways. What about cancer epidemiology? Well, skin cancer, basal more than squamous, much more than melanoma, is the most common cancer not included below. So basal is the most common, followed by squamous. Melanoma is very uncommon compared to the other ones. So we have a little chart that says cancer incidence and cancer mortality. So we can go different ways with this. I want to say, let's say males. Males, number one for incidence, so we know mortality versus incidence. For males, number one for incidence is prostate is most common, then lung, then colon/rectum. But for mortality for men, number one is lung, followed by prostate, followed by colon/rectum. So even though prostate cancer is the most common in terms of incidence, very common, very, very common, it's not as likely to kill you as lung cancer. And the big issue for why lung cancer is more likely to kill you, even though it's not as common in comparison, it's two different things. Well, one thing is that prostate cancer, some people get prostate cancer when they're going to die anyways, and some people very, very many people, or very many men who die with prostate cancer didn't necessarily die from the prostate cancer. That's one thing. Super common though. But at a certain age, there's a lot of other things that are more likely to kill you at that point than the prostate cancer, even if you do have it. And the other thing with lung cancer is that lung cancer, you really can't tell. It's not like good. There's no good lung cancer screening, for the best way I can phrase it. There's breast cancer screening. We have Pap smears. We have all sorts of other things that help do cancer screening. There isn't really like great lung cancer screening, and so when we find out you have it, you're already kind of pretty far down the line. So that's kind of part of the reason why you have a higher mortality for lung cancer than you might otherwise expect compared to some of these other cancers. Colon and rectum is number 3 for both. So what about females? Number 1 is breast, followed by lung, followed by colon/rectum. Okay. What's the mortality rate? Lung is number 1, just like men. Breast is number 2, just like prostate is number 2 for men. And then 3 is, again, colon/rectum. What about children between the ages of 0 and 14? What's number 1? Leukemia, most common, followed by CNS, central nervous system, right? And then followed by 3, which is neuroblastoma. And the mortality rate is the same order. Leukemia, number 1, then CNS, and then neuroblastoma. And what are the notes for the cancer incidence notes? Lung cancer incidence has a decrease in males, but what has not changed significantly in females. So basically, for men, it has decreased over time for men, probably because men are smoking less, but is not decreased is not meaningfully decreased in women. Okay. What about for mortality, cancer mortality? Cancer is the second leading cause of death in the United States. Heart disease is first. True. Okay. What about common metastases? Common metastases. Again, I don't think this section is very abundantly clear to me when I was looking for it, but I'll go into talk about it right now. Common metastases. Most carcinomas spread by lymphatics. Most sarcomas spread hematogenously. Clash. Okay. So carcinomas, lymphatics, sarcomas, hematogenously. Okay. However, 4 carcinomas root hematogenously. Follicular thyroid carcinoma, choriocarcinoma, renal cell carcinoma, and hepatocellular carcinoma. Metastases to bone, liver, lung, and brain is more common than primary malignancy in these organs. So again, let me say that again. Metastases to the bone, liver, lung, and brain is more common than primary malignancy to these organs. So basically, we're looking at metastases at these locations and actually have a native cancer to those areas. So if you have brain cancer, or you have bone cancer, or liver cancer, or lung cancer, think about maybe there is a metastasis from some other location. Okay? Well, you should think about that for many different kinds of cancer, but for those in particular, that's more likely than if you have a native cancer to that location. Metastases often appear as multiple lesions versus a primary tumor, which generally appears as a solitary lesion. Why? Because if you have one metastasis, you can have more than one metastasis, right? You've already established that metastases exist, therefore there might be more. But if it's only a primary cancer, that means you don't know if there's been metastases yet or not. It could be that there's no metastases. But when you have a metastasis already established, that means there already has the potential to do that. So there probably might be more than just one, or there may be more than just one. So what about Sites of metastasis. Is there anything on that? Here we go. Sites of metastasis. Bone. Oh, and also, yeah, talk a little bit about common metastasis right there, sorry. So that is right there, so you can read that out if you want to. So bone, so site of metastasis, primary tumor, and notes. Bone. So prostate, so what's the most likely origin of the bone cancer? Prostate and breast, which is much greater than lung, which is somewhat greater than kidney or colon. But prostate and breast are the most common. Your old book said lung is the most common. Oh, no, sorry, I read that wrong. Prostate and breast is still, no, okay, I was reading it. So bone, yes, bone, still prostate and breast is the most common origin point. Notes. Predilection for axial skeleton, which is shown in the picture, I think. For I think that shows G, picture G, you can see that there. So predilection for the axial skeleton. Bone metastases can be blastic, that is to say for prostate, small cell lung cancer, mixed for breast cancer, or lytic, kidney, colon, small cell lung cancer. What about liver? Colon more than breast, which is greater than pancreas, lung, or prostate. But for liver, number 1 and 2 are colon and breast. Scattered throughout the liver parenchyma. And there might be a picture associated with that. They show C and D for pictures for that. Okay. What about lung cancer? Lung cancer, colon and breast, the most common, and then to a lesser extent, kidney and prostate. Again, colon and breast, just like liver, colon and breast are number 1 and number 2. Well, colon and breast are, I think, are codominant, I suppose, similarly common. But lung typically involve both lungs. So you will have, if you have, I guess, metastasis, I would assume, you will have it in both lungs. If you had a local lesion, let's say you had a pancreas tumor, it might just be in one lung. But if you have a metastasis, it probably would go to both lungs. What about the brain? Most common site of the original tumor, lung, followed by breast. Both of those are much more common than melanoma, which is more common than colon or prostate. Again, lung and breast are most common in this case. Lung and breast or brain. Usually seen at gray-white matter junction. Okay, gray-white matter junction. Also think about where these things are located. Think about brain, think where the brain is located. So lung and breast, you could see it. Melanoma, not so likely. Colon and prostate, those are much farther down in the body. You think they're probably less likely for it to go from the prostate to the brain or colon to the brain, right? Liver, or liver and lung, you could say, okay, colon, maybe from colon, okay. Breast, maybe from breast makes sense, right? Pancreas, for liver, pancreas seems less likely. Well, actually, liver, that sounds like a very likely one, but it's actually not. Lung and prostate, less likely, right? So that one's, pancreas is a bad example, but the other ones, the colon and breast, we can see it. Okay, yeah, sure, why not? Actually, liver's not a good example. Lung's not a bad example, probably. Colon, okay. Breast makes more sense. Kidney, less likely. Prostate, less likely. Bone, prostate is likely, and breast is likely. So sometimes these other examples are not great examples. Just remember which ones are which. Colon and breast are very common for liver and lung. Bone, prostate, and breast are very common. And for brain, lung and breast are very common. But breast is always a very common one of the top 2 for all of them. I think it's number 2 for basically all 4 of them, although technically lung is codominant with it, and so is bone. But breast is always in the top 2. And usually for liver and lung, it's colon is the other top 2. Technically they say top 1 for liver. And then lung is top 1 for brain, and bone is the top 1 for prostate. Or is among the 2. Just to think about it, because obviously if you have a question stem, you can't rule out these other lower, less likely possibilities, but you should be aware of what are the really common ones. Like lung cancer causing lung cancer leading to a brain cancer. Yeah, okay, that kind of thing. Think about that. Oh, okay. This says it's ending, but obviously don't end here. On 220 right now, we wrap up in 225. We're going on oncogenes right now. Oncogenes. Gain-of-function mutations converts proto-oncogene, normal gene, to an oncogene, which leads to an increased cancer risk. It requires damage to only one allele of a proto-oncogene. So gene product, associated neoplasm. ALK, so that's the gene, ALK, gene product, receptor tyrosine kinase, and associated neoplasm, lung adenocarcinoma. EGFR, ERBB1, receptor tyrosine kinase, lung adenocarcinoma. HER2, ERBB2, receptor tyrosine kinase, breast and gastric carcinomas. RET, receptor tyrosine kinase. MEN2A and 2B, medullary and papillary thyroid carcinoma, pheochromocytoma. BCR-ABL, non-receptor tyrosine kinase, CML and ALL. JAK2, non-receptor tyrosine kinase, myeloproliferative neoplasms. Next would be BRAF, BRAF, serine threonine kinase, leading to melanoma, non-Hodgkin lymphoma, colorectal carcinoma, papillary thyroid carcinoma, and hairy cell leukemia. Next is CKIT, CKIT, cytokine receptor, CD117, leading to gastrointestinal stromal tumor, GIST, G-I-S-T, mastocytosis. Next is MYC, MYCC, or CMYC, CMYC. Transcription factor, leading to Burkitt lymphoma. That's an important one. I've been reading about some of those Burkitt lymphoma for a little bit from the last stuff on oncology, so it was just in my mind, I guess. MYCN, NMYC. Transcription factor, leading to neuroblastoma. KRAS, KRAS, RAS GTPase, leading to pancreatic, colorectal, lung, and endometrial cancers. BCL2, anti-apoptotic molecule, inhibits apoptosis, leading to follicular and diffuse large B-cell lymphomas. Now we're going to go into tumor suppressor genes. So those are the oncogenes, right, which causes a gain of function from mutations. You mutate one of these genes, it causes gain of function. What about tumor suppressor genes? These are things that when they lose their function, they increase the cancer risk. So tumor suppressor genes. Loss of function leading to an increased cancer risk. Both two alleles of a tumor suppressor gene must be lost for expression of disease. The nuts and two-hit hypothesis. And so that's different from oncogenes because oncogenes, it's basically about the genes are still functional and they just have a change in their expression, which makes them, basically more likely to cause cancer. So basically, the reason why oncogenes only need one mutation again is because they're not being knocked out; they are just changing how the gene functions, right? However, with tumor suppressor genes, you have to. What's required is that you knock them out. You make them inactive, which means you have to knock out both of them because if one doesn't function, the other one will take its place, basically. Make sense? That's why it's different. That's why it takes two for tumor suppressor genes, why it takes one for oncogenes. So tumor suppressor genes, let's talk about it. Gene product, associated condition. APC, negative regulator of beta-catenin/WNT pathway, leading to colorectal cancer associated with FAP. BRCA1 and BRCA2. BRCA1, BRCA2 proteins, makes sense, leading to breast, ovarian, prostate, and pancreatic cancers. CDKN2A, P16 blocks G1, leading to S phase. This will lead to many cancers like melanoma and lung and pancreatic cancers. DCC, deleted in colorectal cancer. So DCC gene gives you DCC gene product, right? This will lead to a colorectal cancer. SMAD4, DPC4, It gives you DPC protein, I guess, or gene product, deleted in pancreatic cancer, leads to pancreatic cancer, colorectal cancer. That's a little mnemonic that they give you there. MEN1, I'm not quite sure exactly what they call DPC, but that is a mnemonic they can use to remember that. MEN1 leading to MEN-in, okay, which leads to multiple endocrine neoplasia type 1. NF1 gives you neurofibromin, RAS GTPase activating protein, which can give you NF1 or neurofibromatosis type 1. NF2, which gives you Merlin schwannomin protein, gives you neurofibromatosis type 2, which I would assume is the one related to schwannomas. I could be wrong on that one, but I would assume, given it's making schwannomin. Does NF2 cause schwannomas? I would assume. Yes, NF2 causes schwannomas. Yes. Very, very astute observation, or inference, I should say. PTEN, negative regulator of PI3K, AKT pathway, prostate, breast, and endometrial cancers. RB1, which gives you, RB1 inhibits E2F, blocks G1 to S phase, involved with retinoblastoma, osteosarcoma, bone cancer, right? TP53, this is an important one. TP53 gives you P53, activates the P21, blocks G1 to S phase. Most cancers, Li-Fraumeni SBLA syndrome, multiple malignancies at early age, sarcoma, breast, brain, lung, leukemia, adrenal gland. Yeah. TSC1, Hamartin protein, gives you tuberous sclerosis complex. TSC2, tuberin, gives you tuberous sclerosis complex. Okay. So TSC2, tuberin, and TSC1, Hamartin, but they both give you tuberous sclerosis. VHL, which is von Hippel-Lindau, VHL inhibits hypoxia-inducible factor 1A, 1 alpha, I should say, and it can lead to, if it's a damage to it, remember, is von Hippel-Lindau disease. WT1, urogenital development transcription factor. What is it associated with? Wilms tumor, nephroblastoma. Now we're talking about carcinogens. Carcinogens. Toxin, exposure, organ, impact. Aflatoxins, or aspergillus. Exposure to stored grains and nuts. Organ is the liver, and impact would be hepatocellular carcinoma. Okay. Alkylating agent. Alkylating agents, exposure via oncologic therapy, affecting the blood and leading to leukemia and lymphoma. Aromatic amines, for example, benzidine and N-naphthalamine, exposure in the textile industry with dyes or tobacco smoke with N-naphthalamine, affecting the bladder and leading to transitional cell carcinoma. Arsenic, exposure via herbicides with vineyard workers, metal smelting or wood preservation, affecting the liver, lung, and skin, causing hepatic angiosarcoma, lung cancer, and squamous cell carcinoma, respectively. Asbestos, exposure via the old roofing material or shipyard workers, affecting the lungs and leading to bronchogenic carcinoma more so than mesothelioma. Bronchogenic carcinoma more so. Tobacco smoke, exposure is pretty obvious what's going on there. It could be first or secondhand smoke, right? And this is going to affect the bladder, which leads to transitional cell carcinoma, or the cervix, which leads to squamous cell carcinoma, or the esophagus, which leads to squamous cell carcinoma or adenocarcinoma, the kidneys, which cause renal cell carcinoma, or the larynx, which causes squamous cell carcinoma, or the lung, which causes squamous cell carcinoma and small cell carcinoma, or the oropharynx, which causes squamous cell carcinoma, and the pancreas, which causes pancreatic adenocarcinoma. Ethanol, which is going to be affecting the esophagus, leading to squamous cell carcinoma, the liver, causing hepatocellular carcinoma, and the breast, causing breast cancer. Ionizing radiation, affecting the blood, leading to leukemia, and the thyroid, leading to papillary thyroid carcinoma. Nickel, chromium, beryllium, and silica, which is from occupational exposure, affecting the lungs and causing lung cancer. Nitrosamines, when smoked foods. In your book, my book doesn't say it. Well, mine says that nitrosamines smoked foods, yeah. Affecting the stomach, leading to gastric cancer, intestinal type. Radon, affecting the lung. Byproduct of uranium decay, accumulates in basements, affecting the lung, leading to lung cancer, second leading cause of after tobacco smoke. So interesting, radon cancer. Radon-induced lung cancer is second most common. I'm sure it's probably far less likely, but it exists. Vinyl chloride, exposure via the fact that it's used to make PVC pipes, right? And its organ is going to affect is the liver, and it can cause angiosarcoma, or hepatic angiosarcoma, which makes sense because it's affecting the liver. So now what? I have oncogenic microbes, which might have been something that we were looking at before, right? Oh, right here. Okay. I'm going to take a short break. Oncogenic microbes. Microbe and associated cancer. EBV, which leads to Burkitt lymphoma. So microbe is EBV, Epstein-Barr virus, which can cause or lead to something like Burkitt lymphoma, Hodgkin lymphoma, nasopharyngeal carcinoma, primary CNS lymphoma in immunocompromised patients. HBV, so that's hepatitis B virus and hepatitis C virus, HBV, okay? They can lead to hepatocellular carcinoma. True. HHV-A can lead to something like Kaposi sarcoma. That's HIV related, by the way. HPV, human papillomavirus, usually it's type 16 and 18, usually cervical, leading to cervical and penile/anal carcinoma, head and neck cancer. H. pylori, Helicobacter pylori, can lead to gastric adenocarcinoma and malt lymphoma, or maltoma, you could call it that. HTLV1 can lead to an adult T-cell leukemia/lymphoma. Well, that's pretty straightforward. Okay. Liver fluke, Clonorchis sinensis, cholangiocarcinoma, schistosoma hematobium, squamous cell bladder cancer. And I want to go back into that a little bit. Let me just check something quickly. HTLV. Human T cell lymphotropic virus 1. So human T lymphotropic virus 1. Okay. I was just trying to figure out whether or not the HTLV was actually related to the name, adult T cell leukemia /lymphoma, or it was purely a matter of, what do you call it, of just a mnemonic made up. But it refers to human T lymphotropic virus 1, affecting the T cells, lymphoma, right? So it is kind of connected. And remember, schistosoma hematobium, there's 3 different kinds of schistosoma species. The other 2 do not really affect the bladder. It's only the hematobium species that affects the bladder, and that can cause bladder cancer, which is a squamous cell cancer. And liver flukes, again, that's a Clonorchis sinensis. That is a species that you can get from fish. Sinensis implies it's from East Asia, which it is. That can cause cholangiocarcinoma. You can get it from fish, I believe. I think. Now, shellfish. How is Clonorchis transmitted? It says consumption of raw, undercooked, pickled, salted, or smoked freshwater fish. Okay. So freshwater fish. Carcinogens, or no, actually, my book says serum tumor markers, so I'll go into that instead. Serum tumor markers. Talking about alk-phos, alpha-fetoprotein, that kind of thing. So we'll talk about that right here. Serum tumor markers. Tumor markers should not be used as the primary tool for cancer diagnosis or screening. They may be used to monitor tumor recurrence and response to therapy, but definitive diagnosis is made via biopsy. Some can be associated with non-neoplastic conditions. So marker, important associations, and notes. ALK-phos, alkaline phosphatase. Metastasis to bone or liver, Paget disease of bone, seminoma, PLAP. Notes. Exclude hepatic origin by checking the LFTs and GGT levels. Alpha-fetoprotein, hepatocellular carcinoma, endodermal sinus yolk sac tumor, mixed germ cell tumor, ataxia telangiectasia, and neural tube defect. Notes. Normally made by fetus, transiently elevated in pregnancy, high levels associated with neural tube and abdominal wall defects, low levels associated with Down syndrome. So you want to have normal levels. If it's too low, it might be an indication of Down syndrome. If it's too high, it might be an indication of some sort of NTD, right? Some sort of neural tube defect. Human chorionic gonadotropin. In your book says beta HCG, but HCG in mine. High important associations, hydatidiform moles and choriocarcinomas, gestational trophoblastic disease, and testicular cancer, mixed germ cell tumor, produced by syncytial trophoblasts of the placenta. And again, we just want to know if the level is elevated in a way that's atypical or abnormal, because you will have HCG during gestation, as far as I'm aware. Yeah, I believe so, yes. CA 15.3, CA 27.29. Breast Cancer Association. CA 19.9. Association, pancreatic adenocarcinoma. CA 125, associated with epithelial ovarian cancer. Calcitonin, associated with medullary thyroid carcinoma alone and in men 2A, men 2B. Calcitonin, okay, so calcitonin, men 2A, men 2B, okay? CEA, which are medullary thyroid carcinoma alone and in M2NA, okay, whatever. CEA, colorectal and pancreatic cancers, minor associations, gastric, breast, and medullary thyroid carcinomas. Carcinoembryonic antigen, very nonspecific, so it's not specific antigen for CEA. Chromogranin, neuroendocrine tumors. So chromogranin for neuroendocrine tumors. When you hear neuroendocrine tumors, think you should see some chromogranin in it. If you hear chromogranin positive, think, oh wait, what? It's going to be neuroendocrine, right? Yeah, exactly. LDH, okay. LDH, testicular germ cell tumors, ovarian dysgerminoma, and other cancers. Can be used as an indicator of tumor burden. Okay. What about neuron-specific enolase? Neuroendocrine tumors, this is a small cell lung cancer, carcinate tumor, and neuroblastoma. PSA. You hear about this a lot sometimes. PSA, Prostate Cancer Association. Prostate-specific antigen. That's literally why it's called that, PSA. It's not typically a mnemonic, that's why it's called that. Prostate-specific antigen, also elevated in BPH and prostatitis. Questionable risk/benefit for screening. Marker for recurrence after treatment. True. And now we're going to talk about liquid biopsy, if we have a page on that. Liquid biopsy. Maybe we don't. Oh. We might not have anything on liquid biopsy, or for that matter, the staining stuff that we have in here. But I'll look for the stains and look for that. I am not seeing it. Oh, that's another kind of a little frustrating, I guess you could say, a little frustrating. But liquid biopsy is a non-invasive diagnostic test in body fluid, that is to say blood, urine, used using circulating tumor DNA, ctDNA, RNA, ctRNA, or circulating tumor cells, CTCs, for cancer profiling, that is to say EGFR in lung cancer, treatment monitoring and post-treatment surveillance, for example, colorectal cancer, aids in early metastatic detection, and personalized therapy. Important immunohistochemical stains determine primary site of origin for metastatic tumors and characterize tumors that are difficult to classify, can have prognostic and predictive value. Stain, target, tumors identified. So chromogranin and synaptophysin target the neuroendocrine cells. Tumors identified include small cell carcinoma of the lung, carcinoma tumor, and neuroblastoma. Next, we have cytokeratin. Target would be the epithelial cells, and you would have epithelial tumors like squamous cell carcinoma. You have desmin associated targeting muscle, leading to things like muscle tumors, rhabdomyosarcoma. GFAP, associated with neuroglia, astrocytes, Schwann cells, oligodendrocytes, associated with astrocytomas and glioblastoma. So astrocytomas and glioblastomas, those are GFAP positive. Just remember that. Neurofilament, associated with neurons, and you will have associated with neuronal tumors like neuroblastoma. PSA, again, targeted would be prostatic epithelium, associated with prostate cancer. PCAM1 CD31, so PECAM PCAM1/CD31. Target would be endothelial cells associated with vascular tumors like angiosarcoma. S100, target would be neural crest cells associated with melanoma, schwannoma, Langerhans cells, and histiocytosis. TRAP, TRAP, target would be the tartrate-resistant acid phosphatase used for identifying hairy cell leukemia. Vimentin, target would be mesenchymal tissue like fibroblasts, endothelial cells, and macrophages, used to identify mesenchymal tumors like sarcoma, but also many other tumors like endometrial carcinoma, renal cell carcinoma, and meningioma. And now we have the P-glycoprotein thing. P-glycoprotein, ATP-dependent efflux pump, also called multidrug-resistant protein MDR1, expressed in some cancer cells to pump out toxins, including the chemotherapeutic agents, one mechanism of decreased responsiveness or resistance to chemotherapy over time. And again, I'm having difficulty finding some of these things. I have something called paraneoplastic syndromes. I'm not sure if I can find it. Here we go. I'm going to take a brief break. Paraneoplastic syndromes. Manifestation, description/mechanism, most commonly associated tumors. So we're going to go actually start with musculoskeletal and cutaneous tumors. Your book just says cutaneous, but mine has a little bit more categories, I think. Let me see if I can get as much on the page as possible. Okay. Stick to this. So mine says musculoskeletal and cutaneous. Dermatomyositis. We're going to talk about manifestation, descriptions of mechanism, the most commonly associated. Okay. Dermatomyositis, progressive proximal muscle weakness, Gottron papules, heliotrope rash, associated with adenocarcinomas, especially ovarian, acanthosis nigricans, hyperpigmented velvety plaques in axilla and neck, associated with gastric adenocarcinoma and other visceral malignancies. Sign of Laissez-Trele. So is it in your thing? Yes, it is. You can look at the thing, how you spell it, just for reference. Sign of Laissez-Trele. Sudden onset of multiple seborrheic keratoses, associated with GI adenocarcinomas and other visceral malignancies. Hypertrophic osteoarthropathy. Abnormal proliferation of skin and bone at distal extremities, leading to clubbing, arthralgia, joint effusions, periostasis of tubular bones, leading to adenocarcinoma of the lung. Endocrine. Hypercalcemia. You have parathyroid hormone releasing, PTHRP, which is parathyroid hormone related protein, i.e., something that resembles PTH, parathyroid hormone. Associated with S. calcium, that's a mnemonic, squamous cell carcinomas of the lung, head, and neck, renal, bladder, breast, and ovarian carcinomas. You also have increased 125 hydroxy vitamin D3, calcitriol, and you also have elevated risk of lymphoma, associated with lymphoma for that. So squamous cell carcinomas of lung, head, neck, renal, bladder, breast, ovarian carcinomas, and also have lymphoma associated with the vitamin D3 elevation. What about Cushing syndrome? Elevated ACTH and hyponatremia SIADH with an elevated ADH, right? Because it's called SIADH, hyponatremia. Oh, it says hyponatremia, which is from SIADH though, and SIADH is called that because there's an elevated ADH. But both Cushing syndrome and the SIADH associated with small cell lung cancer. Okay? What about hematologic? Hematologic, polycythemia, elevated erythropoietin, paraneoplastic rise to high hematocrit levels, associated with pheochromocytoma, renal cell carcinoma, hepatocellular carcinoma, hemangioblastoma, and leiomyoma. Pure red cell aplasia, anemia with low reticulocytes. Okay. And what about Good syndrome? We have hypogammaglobulinemia. Well, both Good syndrome and pure red cell aplasia are both associated with thymoma. What about Trousseau syndrome? Again, your book says Trousseau, so I don't need to spell it out for you. But Trousseau syndrome, migratory superficial thrombophlebitis, and non-bacterial thrombotic endocarditis, deposition of sterile platelet thrombi on heart and valves, thrombi on heart valves. Okay, both Trousseau syndrome and the non-bacterial thrombotic endocarditis are both associated with the adenocarcinomas, especially the pancreatic form. What about neuromuscular? Neuromuscular, we have anti-NMDA receptor encephalitis. We have psychiatric disturbance, memory deficits, seizures, dyskinesias, autonomic instability, and language dysfunction, leading to ovarian teratoma. Or associated with ovarian teratoma, I should say. That's not necessarily causal. I'm not applying causal per se. It is an association. Opsoclonus myoclonus ataxia syndrome. Dancing eyes, dancing feet. Neuroblastoma, children. Small cell lung cancer, and adults. Paraneoplastic cerebellar degeneration. Antibodies against antigens in Purkinje cells, associated with small cell lung cancer, anti-WHO, gynecologic and breast cancers, anti-Yo, and Hodgkin lymphoma, anti-TR. Paraneoplastic encephalomyelitis, antibodies against WHO antigens and neurons. We also have Lambert-Eaton myasthenic syndrome, which is called LEMS, Lambert-Eaton syndrome though. Antibodies against presynaptic PQ type calcium channels at NMJ. Both the paraneoplastic encephalitis and Lambert-Eaton syndrome, myasthenic syndrome, are associated with small cell lung cancer. Okay? And then we have myasthenia gravis, which are antibodies associated with postsynaptic ACH receptors at the neuromuscular junction that is associated with a thymoma. Okay? Now we have our last page. I hope you're excited to see what the ending is like. I'm not sure if we even have it in this old book. It's our last section, and it's called Aging. It's also our last page. I think it must be a recent edition because I don't remember reading about that one section in the foreword of this chapter. No, it doesn't exist in this book. This old book PDF. We have a new section, which is 1 page long, called Pathology, Aging. Okay? And it says here, normal aging. Time-dependent progressive decline in organ function resulting in increased susceptibility to disease. Associated with genetic, that is to say, telomere shortening, epigenetic, that is to say, DNA methylation, and metabolic, for example, mitochondrial dysfunction, alterations. Cardiovascular. Decrease in arterial compliance, that is to say, increase in stiffness, aortic diameter, increase in aortic diameter, a decrease in left ventricular cavity size, and a sigmoid-shaped intraventricular septum due to a myocardial hypertrophy, increase in left atrial cavity size, aortic and mitral valve calcification, decrease in the maximum heart rate. Gastrointestinal, decrease in LES tone, decrease in gastric mucosal protection, decrease in colonic motility. Hematopoietic, decrease in bone marrow mass, increase in bone marrow fat, less vigorous response to stressors like bone loss. Immune, predominant effect on adaptive immunity, decrease in naive B cells and T cells, preserved memory B cells and T cells. Immunosenescence impairs response to new antigens like pathogens and vaccines. MSK, musculoskeletal, decrease in skeletal muscle mass, sarcopenia, decrease in bone mass, osteopenia, joint cartilage thinning. Nervous, decrease in brain volume, neuronal loss, decrease in cerebral blood flow. Function is preserved despite mild cognitive decline. Okay. Special senses, impaired accommodation, presbyopia, decrease in hearing, presbycusis, decrease in smell and taste. Remember that presby means elder in Greek, right? That's where the word presbyter is from the Greek word for elder. And so presbycusis is referring to a decrease in hearing. Presbyopia refers to impaired, basically the impairment of the eyes because of age. Skin. Atrophy with flattening of dermal epidermal junction leading to a decrease in dermal collagen and a decrease in elastin, wrinkles, senile purpura. Decrease in sweat glands, heat stroke. Decrease in sebaceous glands, xerosis cutis. Xerosis is spelled Xerosis, cutis. Intrinsic aging, chronological aging leads to intrinsic aging, chronological aging, decrease in biosynthetic capacity for dermal fibroblast. Extrinsic aging, like photoaging, i.e., exposure to light, the sun, that kind of thing. Degradation of dermal collagen and elastin from sun exposure. UVA. Degradation products accumulate in dermis, solar elastosis. So that's important to note that there is an intrinsic aging process for skin where there's a decrease in biosynthetic capacity for dermal fibroblasts. So, it's reduced. But the photoaging leads to the actual degradation of dermal collagen and elastin from sun exposure and the accumulation of these degradation products in the skin itself. So be aware of that. The sun does cause you to age. It's just that it's relegated to the skin, and your body still, kind of falls apart otherwise, anyways. But you look better when you're not in the sun, right? Renal. decrease in GFR, decrease in nephrons, decrease in RBF, decrease in hormonal function, voiding dysfunction, urinary incontinence. Reproductive. Males, testicular atrophy leading to decrease in spermatogenesis, prostate enlargement, slower erection/ejaculation, longer refractory period, less pronounced, decrease in libido as compared to females. Sorry, let me do it again. Less pronounced decrease in libido as compared to females. So females will show a much greater or more notable decline in libido. For females, vulvovaginal atrophy, vaginal shortening, thinning, dryness, increase in pH due to a decrease in estrogen from exhaustion of ovarian follicles, menopause. Respiratory, increase in lung compliance, decrease in elastic recoil, decrease in chest wall compliance, increase in stiffness, decrease in respiratory muscle strength, decrease in forced expiratory volume 1, decrease in forced vital capacity, increase in residual volume. TLC is unchanged though. Increase in AA gradient, as arterial-alveolar gradient, increase in VQ mismatch, ventilatory response to hypoxia/hypercapnia is blunted, less vigorous cough, slower mucociliary recurrence. Okay. And then finally, the section on lipofusion, still part of the aging section though. Lipofusion, a yellowish-brown wear and tear pigment, shown in a little picture here. It's kind of like this orangish-brown color, right? Golden brown, associated with normal aging, composed of polymers of lipids and phospholipids, as complex of protein, may be derived through lipid peroxidation of the polyunsaturated lipids of subcellular membranes. Autopsy of older adults will reveal a deposit in the heart, colon, liver, kidney, eye, and other organs. Okay. And that would conclude our chapter, basically, for pathology. Now, pathology was interesting because it's kind of like a grab bag of a lot of different things. Pharmacology, I guess, is in a similar camp, technically speaking. But I felt for pathology in particular, it felt like it was kind of like the leftover stuff. So, when we discuss about GI issues, we discuss all the GI problems and pathologies. We go over, I'm not going over that chapter yet in this book, but in theory. Same thing with respiratory system. They'll have a pathology section, respiratory, talking about respiratory diseases, right? And so most of the diseases we're going to cover are going to be in their respective chapters. This section felt like more like a grab bag of some of that stuff, plus some stuff that we haven't really covered that would not be covered in these other chapters anyway. So I just want to make sure that they round out any diseases they otherwise would have missed, that kind of thing. That's what it kind of feels like, But anyways, if you've stuck around for this entire video, well, thank you for watching, but I really hope it's been of good use to you. But thank you very much, and bye.